What I'm going to talk about is the changes in the way we've been thinking and approaches to ankle and TTC arthrodesis over the past 3 or more decades. Here's my disclosure. I am a consultant or receive royalties from the following companies. And by disclosure, I am one of the designers of the plates that I'm going to present tonight. I think when we discuss ankle arthritis, there are 2 or 3 basic varieties. One which I call pretty arthritis. The joint is fairly well aligned. There's not much bone loss and are relatively straightforward to fuse. Then you've got ugly arthritis. These are difficult. Obviously, you need realignment, and isolated ankle arthrodesis sometimes is not enough for these. And you obviously need different types of fixation products. And then you've got these terrible deformities where you have to anticipate more significant problems with your fixation. Now, when we come to the first one, pretty arthritis, I think that it's very reasonable to consider an arthroscopic approach. For those of you who are accustomed to and familiar with the arthroscopic procedure, this has been around a long time. And I started doing arthroscopic ankle fusions in the mid-1980s. And towards the end of the 80s, George Kuhl and I, we published a comparison of an open arthroscopic method of treatment in a well-compared group. And I think that there probably is a role for arthroscopic fusion. When you look at the results of 2 major studies, here is one with a large number of patients with a reasonable rate of arthrodesis, but no deformity nor high-risk cases were included. In this study from Canada yielded equivalent results from the 2 groups, but again, the arthroscopic group had less deformity. So clearly there's an indication for arthroscopic procedures, but you've got to realize that deformity correction can be difficult, particularly when your fibula is hypertrophy, and you've got to think of the ankle as a mortise, and it's not that easy to get compression, particularly when the talus is trapezoid and compression can be blocked. So you're not able to generate sufficient compression in some of these cases, particularly when there's hypertrophic osteoarthritis present circumferentially. When you've got deformity that is fixed, as you have here, an open approach is certainly necessary. But of course, it begs the question, how are you going to do the open approach? And I think that this is very important. Sometimes you end up with problems, and you can see here with an open approach has ended up with a malunion in equinus, which can happen regardless of the type of approach that you use. Now, the arthroscopic approach that I started with in the 80s led me to believe that the main advantage to doing this was not only visualization of the joint, but the lack of periosteal stripping around the joint. And I switched to what we called a mini arthrotomy approach. This was in the early 1990s, and all it was with 2 small incisions enlarging the arthroscopic portals, and we called this, as I said, the mini arthrotomy approach. And then I decided to look at this more carefully, and we did angiographic examination of cadavers. And here you can see on digital subtraction angiogram, in the middle is the mini arthrotomy ankle arthrodesis, and you can see the vascularization of the ankle is still intact. But on the far right, whenever you do an osteotomy around the ankle, particularly of the fibula, you destroy the blood supply to the talus, and it's significantly affected. And this is the technique that we followed really even up until today. I think that there is a role for this mini arthrotomy approach to the ankle. You can see here, after you've done your debridement with a laminar spreader, you drill the joint and you provide compression fixation, as you see here. Now, flexible deformity, provided of course it is flexible, can also be corrected with this mini arthrotomy fusion approach. Here you'll see a patient who's obviously undergone, it looks like a calcaneal osteotomy and an attempted ankle ligament reconstruction with a very severe varus deformity of the ankle. What I like to do in planning the treatment is to start out, before I even make any incision, is to determine, is this ankle mobile or not? If the ankle is rigid and stuck, then I would prefer a more extensile approach anteriorly, and I would use an anterior plate for fixation. If the joint is, however, reducible and mobile, then I think you can still proceed with minimally invasive techniques. And you can see here, under fluoroscopy, the ankle is quite mobile. I was able to correct the deformity and proceeded with the mini arthrotomy approach and the fixation that you see here with 3 screws. One of the things about this 3-screw technique, which has been very popular over the decades, is you need to think of the surface area of the talus. And it's probably at its largest diameter, probably only 2.5 to 3 centimeters in diameter. Now, if you put 3 screws across the center of the talus, and these screws are measuring 6.5 or 7 millimeters in diameter, then what happens is that you've got less and less bone available for actual surface-to-surface compression and arthrodesis. And this is very important when it comes to planning your type of fixation. I made a mistake here with this particular case where I thought I could use a minimally invasive approach in the setting of obvious avascular changes in the distal tibia and talus, and that despite the fact that I used bone graft, this dissolved very, very rapidly, and I had to switch to an open approach. So selection of your cases for minimally invasive techniques and procedures needs to be done obviously carefully and under the right circumstances. And cases like this clearly are not going to be amenable to any minimally invasive approach. On the left, you see significant deformity of bone loss. In the middle example is one of a non-union of an ankle, which cannot be revised using a minimally invasive approach again. And then, of course, when you've got avascular necrosis, whether this is of the tibia or the talus, you need an open approach. And I think that plate fixation is a very reasonable alternative to consider when you are planning an open approach to these joints. Now, remember what I said earlier about the blood supply to the ankle. If you do an osteotomy of the fibula, as we do routinely for a transfibular approach, whether it's for the ankle, if you're going to go laterally, or for the TTC arthrodesis when you're going laterally on a transfibular approach, you do disrupt the blood supply. And indeed, it's only when there's a specific indication. This is one of the Paragon fusion plates. It's a lateral ankle fusion plate. In this particular patient where there's a free flap anteriorly, which extends right over the front of the joint, and any minimally invasive approach would not work, and in particular here, an extensile anterior approach would not work either. So a transfibular approach is acceptable. And in this case, I think that it's not unreasonable to consider a transfibular approach laterally with a plate fixation. I would recommend, wherever possible, to use an anterior plate, but then you have to think of what type of plate to use. There are many plates that are currently available on the market, and I caution you to be aware of how these plates work. Here you can see a non-union of the ankle. It's very easy to see this, and I decided to continue with a plate fixation, but the non-union persisted, because what happens with some plates is you get compression in the front of the joint only, and the back of the joint remains open. And there are certain requirements that are present for a good plating system. You have to be versatile. You have to have a right and a left plate of different thicknesses. The thicknesses are important because you cannot use a thick anterior plate where your skin is particularly fragile and thin. So it needs to be a thin plate that's not palpable subcutaneously. When you go to the heavier, thicker plates, they may be indicated in certain cases, particularly a Charcot ankle if you find that a plate is indicated. But you've got to find a plate that's going to meet the needs for all types of deformities. As I said already, it has to be very low profile with no skin prominence. and you must have high compression with the system. And I say system because whether you're doing an isolated ankle fusion or TTC fusion, you've got to have very, very good compression. And none of the systems that are available, whether you consider them plates or plating procedures or intramedullary fixation, have adequate compression across the ankle. And we need to discuss this. And you also want to be able to convert your ankle fusion to a TTC fusion intraoperatively if the need arises. So let's take a look at this plate. Here's the Paragon ankle fusion plate from the front and side, and it comes in two sizes, standard, and as I said earlier, there's a right and a left, and a much longer plate when you're dealing with bone loss or perhaps in a Charcot ankle. It's called the Silverback ankle fusion plating system. I think the Silverback has something to do with after the gorilla, although I can't be sure of that. And this is what it looks like. The plate has only been released a week ago, so I'm going to show you only cadaveric slides, but the plating system is available. One of the nice features of the plating is that it comes as a system. So you've got your laminar spreaders, you've got your dissecting tools to debride your joint. And perhaps most importantly is the way the plate contours over the front of the ankle. Remember that for all ankles, no matter how you're going to approach them, no plate is going to fit when you've got hypertrophic osteoarthritis over the anterior ankle. So some type of debridement is going to be necessary in order to get your plate to sit down nicely. So you'll start out with your distal 2 screws. Now there are 4 screws distally, but we're only going to position the plate with the 2 positioning screws distally, and then you've got your positioning pin right through the plate in the tibia. Now at this point, you have to choose what type of compression you're going to provide or apply to the ankle. Now, I'm going to show you a number of different ways of obtaining this compression. You can go through your compression slot, but you'll notice that if you do it through the compression slot here, the screw's not compressed down all the way. This is just going to be positioned in that place, and you'll compress it down later because you can use this arm here is what's called the precision guide. And for those of you who are familiar with any of the Paragon fusion plating systems, they all come with a precision guide so that you're able to target your malleolar screw that comes in slightly posterior, slightly medial, in a number of different positions in order to get the trajectory correct right down through the body into the lateral process of the talus. Once your screw is in, at that stage, you can then compress it. Now, there's an entirely different way of thinking about this fusion, and that is, what if you had the ability to really compress the joint tremendously before you even got started? So let us take this compression system, which is available, and now you applied your compression, you've got your plate on the talus, as I've showed you earlier, and then you can supplement it either with your compression slot in the compression slot hole proximally, or you can add your oblique malleolar screw. So this compression system is very, very effective. And most importantly, it gives you axial compression. One of the problems, as I said earlier, is that many of the plating systems that are currently available compress it only anteriorly. But if you've got your compression directly axially under the tibia, you're going to get concentric compression all the way across the joint. I'm going to switch a little bit to deciding when do we do an ankle or TTC arthrodesis, because there's some ankles, obviously, where you've got deformity and arthritis. On the left, clearly there's not much bone available, and you probably would choose a TTC arthrodesis. But on the right, you can easily get away with an isolated ankle arthrodesis. It's just a matter of what kind of approach are you going to use to fix this. But we know that there are a lot of problems associated with ankle arthrodesis in the long term. This is one paper which shows that following ankle arthrodesis, subtalar and talar navicular instability occurs. And this is a major issue which may have something to do with the development of osteoarthritis later on. We don't typically get this x-ray in our clinic when we're evaluating the patient because we'll get weight-bearing x-rays. But what happens is when you're walking and the foot goes into plantar flexion, you can see in the back of the subtalar joint, there's tremendous compression that is taking place in your subtalar joint, and that may explain why there's such a high incidence of peritalar arthritis. And in this very important study by Saltzman and his colleagues, they showed an almost 100% rate of arthritis 10 years following an ankle arthrodesis, which means that your rate of peritalar arthritis is really high. Not all of these patients require conversion to a subtalar, or in this particular case on the right, a pantalar arthrodesis. But nonetheless, it's something to be concerned about. Now, how do you know when to choose between an ankle or a subtalar fusion? We'll have to explore this a little bit. One of the studies which we started out with, you must remember that in the early 1990s, 1980s even, we didn't think in terms of plates. Intramedullary rods were not available and were not being used at this time, and most of the work that we did was with screws. But what we found very early on was that if the subtalar joint was stiff, it was preferable to include it in the arthrodesis and not to try and leave it alone. And there's another reason why. We did a study some time ago. My fellow from England, Adam Agis, looked at a matched group of patients who had ankle arthrodesis, as you see on the left, and a TTC on the right. And surprisingly, the clinical outcomes and return to activity were the same for these two groups of patients. Now, you would say that's really not possible. How can a patient with a TTC arthrodesis have the same clinical outcome and return to function? Well, what probably happened is that with the TTC patients, they had greater level of deformity and the magnitude of problems preoperatively were higher, so that their outcome and the outcome measures that were used did not stratify the two groups. Nonetheless, what we did show, which is important, is that these two groups were very similar in their clinical outcomes. In the late 1980s and beginning through the 1990s, we switched to a blade plate. This was available. The blade plate, of course, was not designed for use in the ankle. In fact, this was a plate used. It was a supracondylar femur plate, but it was very, very effective. And we showed that in patients with neuropathic deformity, we used a plate almost routinely, and it was a laterally applied plate. Now, when we come to these kind of deformities, you recognize that in the setting of avascular necrosis or very bad deformity, a TTC arthrodesis is obviously going to be necessary. This is not a maybe. You have to perform a TTC arthrodesis. So now the issue is, what is going to be the ideal approach to this? Are you going to use screws, plate? If you're going to use a plate, where are you going to apply the plate? Anteriorly, laterally? I think wherever possible, if you can go anteriorly or posteriorly for TTC fusion, and my preference would actually be to go posteriorly where possible, you perform as little devascularization of the joint as possible. You gain access for compression, and there's no stripping of your fibula to create any problems with your vascularity of the joint. Here you can see a pretty standard TTC arthrodesis, which ended up as a pantalar arthrodesis with a non-union of the ankle, as you can see quite easily there. And this was converted to an intramedullary rod successfully. As a generalization, when you've had problems with screws, you have to switch to a different system. And the same thing applies to an intramedullary rod. If you've used an intramedullary rod for TTC fusion and it fails, you've got to switch over to a plate. And then the selection of plate and the positioning of the plate becomes very important. Now, I'm going to present a few cases of fusion using an intramedullary nail, but I want to caution you. And the reason is that even though we all have good results with intramedullary fixation, and I was one of the designers of this particular nail, there are problems, and there's very little fixation of the calcaneus. And you can see there, you've got a non-union of the ankle that might just have been due to bone loss and has nothing to do with the type of fixation. Although when you can anticipate bone loss, you certainly should use an alternative approach and perhaps focus it anteriorly or posteriorly with a plate. But this is the problem that I think we get into, where we don't appreciate the fact that when you look at the rod from the lateral side and you position your rod, if you look at the AP on the left and your middle image, the rod is now centered in the tibia. But in order for it to be centered in the tibia, you're medial in the calcaneus. Now, there are only two ways to get around this. One is to shift the entire construct medially, and the only way you can do that is to do a medial malleolar osteotomy so that you can physically shift the talus and calcaneus medially. And the other is to use a curved rod. Now, there are curved rods that are available, but I have a problem with them. And the reason is that when you introduce a curved rod from the lateral side, it overcompresses laterally and pulls the heel into valgus. And for that reason, wherever possible, I try to avoid an intramedullary rod. And we all have cases, as I will show you here, where this is an outstanding result, and I've managed to recover both length of the limb as well as axial and coronal plane alignment. But I do think that you have to rethink the way you're going to fix various fusions. There are other cases like this one where there's no way you can do this anything other than with an intramedullary rod, because this required an osteotomy of the tibia simultaneously. Now, what then is the role for plate fixation of TTC arthrodesis? So I think that if it were my preference today, I would avoid an intramedullary rod wherever possible. I would prefer to use a plate for fixation, but it depends what type of plate, because the plate has to be anatomic. It has to fit, whether it's going to be a lateral or a posterior or an anterior TTC plate. And you've got to have excellent compression, and therein is the key. You need compression. So there are alternatives. This is the main reason why I think you must consider plates. This is really an excellent study, and I would like you to look at the joint forces that are across the ankle with screws, nails, and plate. So as you progress from screws through an intramedullary nail to a plate, both in the ankle and the subtalar joint, you're getting increasing compression, which means that a plate gives you more compression than a nail and much more compression than screws. Now, based on this, you then have to select the plate and make sure that you've got a plating system that does generate compression. In the old days, we didn't have these plates. This is not a TTC plate at all. It's not even designed. It's not anatomic. You can see it's protruding inferiorly. This is actually a humerus plate. But probably 20 years ago, this was all that I had available at the time. There are other plates that are available on the market, but if you look at these are not necessarily anatomic, and the points of fixation on the talus and calcaneus are minimal, if any, and these plates are too thick. They're not contoured well. Now we have a couple of options. Remember I said earlier that your one alternative is to take your ankle fusion plate, and if you recognize the need for a TTC fusion, you don't have to change it. You've got your plate already there. Just convert that to a TTC fusion by making a small incision over the sinus tarsi, and now using your screw hole in the plate already, which is there for you, and using a precision guide system to guide you as to where your screws are going to go. Now, once again, compression is terribly important. This system generates an enormous amount of compression. It's got a cup that fits over the back of the heel, over the skin pad, and applies a tremendous compression to the subtalar joint. Remember, you've already, if you've done your ankle fusion, I showed you the earlier compression system that's available for the ankle. This one allows you to compress just over the subtalar joint. Now, in my opinion is that wherever possible, if you can get sufficient compression externally, why rely on a screw with partial threads? Because so often, as I'm sure you've experienced, you insert your screw, and just before you want to get that final last turn and bite, it strips. And now you've got absolutely nowhere to go. It would be much nicer to have better fixation using a fully threaded screw. So my preference would be to use external compression, get tremendous compression over your joint, and then use fully threaded screws. Now here you can see there's one fully threaded screw being inserted anteriorly. There's also a guide system. So this is how it would work. You'd apply the compression. You've got your guide system, which allows you and helps you find and seat your second screw that goes directly across the posterior facet. Remember, again, you've got this through compression. And then finally, your other alternative, there's one more plate that's part of the system that I'm not going to be showing you here. It's still in development. It's a posterior TTC plate, which I think is absolutely wonderful because it's contoured anatomically, and it really is ideal because it doesn't devascularize the joint at all. But this really is well thought out because you're able to use the same compression that I showed you earlier for the ankle, get compression, and then apply your anatomic plate. So here's the compression system that I showed you for the ankle. You can apply it here to the TTC as well. You generate compression. Here you've got the precision guide. I showed you the precision guide for the ankle. It's very similar in concept here, so that your screw system that goes across your subtalar joint will miss all of those screws that are in the talus. And finally, once you've got your screws in, and you can see there how it works, you're able then to continue to fill your screws and remove your precision guide. So if I were to summarize this, as I look at TTC fusions, in the 1980s, all we had was screws, and that's all we used. That changed perhaps in the early to mid-1990s when I started using a blade plate for fixation. In the late 1990s, there was the first generation of intramedullary nail, which these really were not very good because it did not provide you with adequate compression nor rotational control of the hindfoot. The early to probably by about 2004, 2005, the second generation of intramedullary nails were available, and since then there are quite a number on the market, which I think are fairly good, but they have their limitations, and you have to be careful about the anatomic use of these. And that leaves us now with the plate, which I think brings us to what I would consider the modern era, because it fulfills the requirements that we're looking for: alignment, anatomy, and compression. With that, thank you very much for your attention. I'm happy to take some questions. What is my opinion about the consolidation with the intramedullary nail system? Okay, so when you look at the retrospective studies that have been done on intramedullary nail, they're reasonably good. I think that they range from about 85 to 90% fusion, rate of fusion, but you have to remember that every case is different. So you cannot put all your TTC fusions and analyze them together, because some have avascular necrosis, some of them have neuroarthropathy, and they may be a Charcot ankle. Some have severe deformity and bone loss. So you have to, I cannot answer that as a standard for subtalar fusions. I think this next question is a very, very relevant one. Do you always fuse a healthy subtalar joint? Absolutely not. No. What I was trying to say was that if the joint is stiff, if there are clinical findings of sinus tarsi pain, I would prefer to include the subtalar joint in the arthrodesis. By and large, if I look at the patients with ankle arthritis, I would say 80% of them would end up with an ankle fusion and 20% with the TTC fusion, where there's ankle and subtalar joint arthritis. But if you've got stiffness and or arthritis of the subtalar joint, I think that an arthrodesis of both joints is really preferable. There's a lot of biomechanical evidence and gait analysis that is available from Europe, in particular from Madrid, that has been done both by Ernesto Macera and other colleagues, Manuel Monteagudo, who have shown that on gait analysis, patients with a TTC fusion, actually their gait and stride is better than that of an isolated ankle fusion. So there's another question here, the compression devices that I showed. Yes, these are both these are Paragon compression guides, and are they both theoretical to show precision guides? So both of these, the compression systems that I show, are part of the fusion system, both whether it's isolated ankle or the TTC. And the precision guide is standard for all of the Paragon fusion product, because it allows you to insert your screws and then get your cross screw that misses all of the other screws that are already holding your joint. So that's the advantage of the precision guide. Now, this is an interesting question, and I think it does warrant a little discussion, and that is, what about positioning of patients prone? Well, I think that when you position a patient prone, there is clearly the potential for increased morbidity, undoubtedly. And if you have an obese patient, not all tables have a device where the stomach can drop out. So yeah, there are obviously increased anesthesia risks with a prone position. Nonetheless, it's still my preference. You know, one of the things about a posterior approach for a TTC fusion is it's very easy to position the fusion. If you're doing a lateral transfibular approach to a TTC fusion, you cannot determine internal and external rotation from the lateral side with a patient in a semi-lateral or supine position. It's impossible. But with the patient prone, it's very easy. Next question here. When I've done an arthrodesis with an anterior plate, no, you never want to touch the fibula if you're going anteriorly. Leave it alone. If I do believe that if you resect the fibula, it does have an influence on the outcome of your arthrodesis. I really feel strongly about leaving the fibula intact. Now, if there's hypertrophy of the fibula or large osteophytes which are blocking reduction, you don't need to cut the fibula. Just through your anterior approach, take an osteotome or chisel or a reciprocating saw and clean out the lateral gutter. You do not need to do anything. You certainly don't need to do an osteotomy of the fibula. So that's it. Thank you, everybody. Lisa, I think that's all of the questions.
Thank you so much, Dr. Myerson, and thank you again to Paragon 28 for hosting. Have a good evening, everyone.
Thank you.